In this particular section, we are going to discuss on the MEN syndromes. MEN syndromes are nothing but multiple endocrine neoplasia. There is another group of syndromes which we are going to discuss after the MEN syndromes, that is called the MEONs, that is multiple endocrine other organ neoplasias. So what is the difference between MEN and MEONs? The MEN syndromes generally have predominant endocrine tumors, whereas in the MEONs, they do have some endocrine neoplasms, but they have predominantly extra endocrine neoplasms with associated endocrine tumors. So these are the major differences between the MEN and the MEONs. So without wasting much time, let us move on to the MEN syndromes, which is not so common, but very important as far as exams are concerned. So MEN syndrome can be divided into three types. One is called a MEN1 syndrome. Second is a MEN2 syndrome, where you have two categories called MEN2A and MEN2B. Previously, they are called as MEN2 and MEN3, but right now they have been renamed as MEN2A and MEN2B because both are due to the common gene mutation, that is red proto-oncogene mutation. So that's why they are classified under 2A and 2B right now. Previously, they have been called as 2 and 3 respectively. So we have the fourth type also, that's called the MEN4 syndrome, which is one of the very least studied among the MEN syndrome, that is MEN4 syndrome. So let us see as a difference so that you can understand, what are the contrasting features between these syndromes. So MEN1, MEN2A, MEN2B, and MEN4. So first one, what are the other names for that? So MEN1 is also referred to as a Wermer syndrome, whereas MEN2A is referred to as a Sippel syndrome, and MEN2B is referred to as Wagenman-Frobo's disease. Wagenman or Wagenman-Frobo's syndrome. Clear? So MEN4 doesn't have any specific name for it, special name for it. And what is the problem? What is the genetic problem underneath these MEN syndromes? First, in MEN1, it's the MEN1 gene that is the problem. And MEN1 gene is present in chromosome number 11. Please note that MEN1 gene is a tumor suppressor gene, TSG. It's a tumor suppressor gene. Remember, usually the reason why you get a tumor due to problems in the tumor suppressor gene is due to inactivating mutations. Because of the inactivating mutations of the tumor suppressor gene, you might result in excessive cell proliferation and tumor. So MEN1 is a tumor suppressor gene. Inactivation of this tumor suppressor gene will result in MEN1 syndrome. And MEN2A and MEN2B are due to red proto-oncogene mutations. Remember, red is a proto-oncogene. So they are present in red proto-oncogene is present in chromosome number 10. So here chromosome number 11, in red proto-oncogene it is chromosome number 10. Very, very important. And let us see the codon mutations later on. But in MEN2A, the most common mutation, if they ask you, the answer will be codon 634 mutation. Clear? This is the usual mutation that you will encounter in a MEN2A syndrome. There is a variant of MEN2A we'll discuss in some time, that is called FMTC, that is called the familial medullary thyroid cancer. That's called FMTC. This FMTC variant will have this codon 618 mutations. If they ask you what is the most common red proto-oncogene mutation in MEN2B syndrome, the answer will be codon 918. So this is the most common mutation that is associated with MEN2B. Remember, even though we classify the disease as MEN2A and MEN2B, it is the codon mutation that is very important, and that is the thing that determines the disease features. For example, we tell that MEN2B has one of the highest risk for developing medullary thyroid cancer. So actually, it's not the MEN2B that is having highest risk of developing medullary thyroid cancer. It is actually the codon 918 that predicts the development of highest risk of medullary thyroid cancer, which means it's the codon mutations that is underlying this MEN syndrome that is what is predicting the clinical features of the particular patient. So these are more important than the subdivisions of MEN syndromes itself. So the most common in MEN2A it is 634 and FMTC it is 618, whereas in case of MEN2B, that is codon number 918, which predisposes to one of the highest risk for developing medullary thyroid cancer. And MEN4, it is the cyclin gene that is CDKN1B. That's a cyclin-dependent kinase. That is the genetic defect. That's a mutation that happens in MEN4, which is present in chromosome number 12. Remember, the mutations of the CDKN1B gene is not well characterized, even though it is well characterized in exams. You have to ask them. I mean, you have to answer them. So CDKN1B, very, very important question in exam for MEN4. Okay, now let us see what are the tumors that you're going to encounter in case of, like these different MEN syndromes. Let us see what are the endocrine tumors that you're going to encounter. The first one, I'm going to put as a parathyroid adenoma. Parathyroid adenoma. Second one, I can tell a pituitary adenoma. Then let me put a pancreatic neuroendocrine neoplasm. Then the fourth tumor is a medullary thyroid cancer, and the fifth tumor is a pheochromocytoma. Clear? This is the fifth tumor, pheochromocytoma. So these are the 5 tumors. I'm just going to tell where you're going to get these tumors. Remember, parathyroid adenoma, yes, in MEN1, and again, yes, in MEN2A syndrome, but no in case of MEN2B, and again, yes in case of a MEN4 syndrome, which means the only syndrome that doesn't have a parathyroid adenoma is a MEN2B syndrome. Very, very important point. And pituitary adenoma is an exclusive feature usually of a MEN1 syndrome. Very rare in other syndromes. Can be seen to an extent in MEN4, but you don't see in MEN2. It's not a feature of MEN2A, as I told you already. It's not a feature of MEN2B actually. It can be seen in MEN4, but very rare. Pancreatic neuroendocrine tumors, again, really exclusive for MEN1 syndrome, which is seen only in MEN1, not a feature of MEN2A, not a feature of MEN2B, and not a feature of even MEN4 as well. And about medullary thyroid cancer, is not seen in MEN1 at all. This is an exclusive tumor of MEN2 syndromes. It is due to red protein oncogene mutations. It can be seen in MEN2A, it can be seen in, yes, MEN2B, and it's not seen in MEN4. And pheochromocytoma again is a tumor of red protein oncogene mutation, so which means it will not be seen in MEN1, it will not be seen in MEN4 as well. It will be seen in MEN1 and MEN2A and MEN2B. Fine. So if they ask you the most common clinical feature or most common tumor associated with MEN1 or most common MEN1 associated tumor, answer will be parathyroid adenoma. Very important point. Second, if they ask you the most common pituitary tumor in MEN1 or most common pituitary adenoma in MEN1, again the answer will be prolactinoma or a lactotroph adenoma. This is the most common pituitary adenoma in MEN1. Similarly, if they ask you the most common pancreatic neuroendocrine neoplasm in MEN1, answer will be a non-functioning tumor followed by a gastrinoma causing Zollinger-Ellison syndrome. So after gastrinoma, it's insulinoma, all right, but most commonly it's a non-functioning tumor. Remember, the confusion usually starts from Harrison because Harrison will mention in some place as PPoma as the most common. It's very simple because it's been proposed that a lot of these non-functioning tumors secrete this pancreatic polypeptide as well, which means this pancreatic polypeptide secreting non-functioning tumors, I mean, they are considered non-functional only. You might ask me the question, but this is what we refer to as a PPoma, which means indirectly the PPomas are the most common, right? So non-functioning tumor or a PPoma, both are correct. But remember, the most common functioning tumor in a MEN1 syndrome must be gastrinoma. Clear? So again, it has been changed a lot of times. Don't think about Harrison. Harrison, even the latest 20th edition, they have been giving an old table. The same author who has proposed that table and a particular article has changed the table in 2011. Still, Harrison 20th edition is giving the 2005 table. So, like it is a little bit old. The same author of that particular table from the particular article that is given as a reference has changed the table in 2011, which is not yet updated in Harrison. That's all. But the most common will be the non-functioning tumor or a PPoma. Clear? So second most common is the gastrinoma. Third most common is the insulinoma. If they ask you most common functioning pancreatic neuroendocrine neoplasm in MEN1, answer will be a gastrinoma then. That's all. And remember, this pancreatic neuroendocrine neoplasm is also the most common cause of death in these patients. Most common cause of death in MEN1 patients is a pancreatic neuroendocrine neoplasm only. All right. So if at all they ask you the most common clinical feature or most common tumor that is associated with MEN2 syndrome, your answer must be medullary thyroid cancer. So this usually happens yearly, and one of the most common tumors that are associated with MEN2 syndrome, both MEN2A and MEN2B. So remember, usually this pheochromocytomas happen later by around 5 to 10 years. They lag by 5 to 10 years after this MTC. The MTC will be the earlier finding compared to that of the pheochromocytoma. And again, this is very important. And remember, MTCs that are associated with these are familial MTCs. Whenever MTCs happen in association with MEN2 syndrome, it is a familial MTC. Even though MTCs are common sporadically, which means sporadic MTCs are more common. 85% of the MTCs are sporadic. Only 15% of the medullary thyroid cancers are familial, but their association with MEN2 syndromes are seriously important for exams. And the familial MTCs that are associated with MEN2 syndromes tend to be extremely aggressive. And these MTCs tend to be the most common cause of death in patients with MEN2 syndromes. But what about these pheochromocytomas? If you think about these pheochromocytomas generally tend to be bilateral because they are familial pheochromocytomas, genetic based, and they are bilateral usually, but they tend to be benign. They do not tend to be that aggressive or malignant compared to the MTC. So that's the reason I told you this MTC tends to be the usual cause of death in these patients. So let us discuss some of the important aspects of this later on. Because whenever you do a surgery for MTC in a patient with MEN2 syndrome, it always a must to rule out a pheochromocytoma underneath. You have to evaluate for a pheochromocytoma because in the presence of pheochromocytoma, if you touch the tumor or if you do a surgery, the pheochromocytoma might explode and you might result in death on table. That's the reason it's always mandatory to rule out a pheochromocytoma before operating for an MTC. To operate an MTC in the presence of pheochromocytoma, you have to operate pheochromocytoma first to prevent the sympathetic surge, and then you go for the MTC surgery. So that's why it's very, very important to test for pheochromocytoma in any patient with MTC and probably a familial MTC like MEN2 syndrome. Okay, so now not only these features, you're also going to get other features like other miscellaneous features you can get. What are the other features that are characteristics of MEN1 syndrome? You can get angiofibromas. Remember, these angiofibromas tend to be the most common extraendocrine feature, or apart from the endocrine tumors, the most common apart from endocrine, most common extraendocrine tumor will be the angiofibroma in MEN1 syndrome. They can get collagenomas, and they can get adrenal cortical tumors. All right. Please also note the fact that these patients are more prone for foregut carcinoids. That's again very important, foregut carcinoids. Why that point is important? Because remember, carcinoids are extremely common in the midgut, not in the foregut. So what is the most common site for a carcinoid? Controversies apart, like your distal part of the midgut, that is your appendix, tends to be the most common site for carcinoid, followed by the distal ileum. No controversies. This is the most common site. GIT is the common site. In the GIT, the appendix tends to be the most common, followed by the distal or the terminal ileum. Fine. So, which means in general population, your carcinoids tend to happen in the midgut, not in the foregut. But in MEN1 syndrome patients, the carcinoids tend to happen more commonly in the foregut. In the foregut, there are three areas where you can get. One is a lung carcinoid or a bronchial carcinoid. Then you can get the thymic carcinoid. All these are foregut related structures. Only you might ask me how a lung or a bronchus can become a foregut structure. Remember, lung develops from the foregut endoderm. Like as a lung pouch, a lung node, and that is the one that grows into the lung bud. So it is technically or embryologically a foregut structure. So lung carcinoid or bronchial carcinoid is a foregut carcinoid. Thymic carcinoid is a foregut carcinoid, or you can get a gastric carcinoid. Among the three, which is going to be the most common? It's the gastric carcinoid. That's going to be the most common, which means it can be seen in both males as well as females. Whereas bronchial carcinoids tend to be more common in females, whereas thymic carcinoids tend to be more common in males. Whereas overall most common type of foregut carcinoid in MEN1 syndrome is this gastric carcinoids. Fine. And they can also develop lipomas. So you have to note that also. They can also develop multiple lipomas. What are the other features of MEN2 syndromes? MEN2A, you have to know the subtypes and variants of MEN2A. That's the most important rather than knowing other things. What are the variants of MEN2A? You have MEN2A that is associated with cutaneous lichen amyloidosis. Remember, this is a separate entity. This is a variant of MEN2A called as MEN2A with cutaneous lichen amyloidosis. Number 2, you have a familial medullary thyroid cancer where the patient will have only medullary thyroid cancer, no other feature. So codon 618 mutations we have studied, that is associated with FMTC, only MTC. That's a variant of MEN2A that's called M2A with only MTC, that is familial medullary thyroid cancer variant. Third one, you have another variant that is called MEN2A with Hirschsprung disease. MEN2A with Hirschsprung disease. Fine, all right. What about the MEN2B? MEN2B syndrome has typically some of the other features which are really important for exams. One is the mucosal neuromas. In fact, if they ask you the most common extraendocrine feature of MEN2B, answer will be mucosal neuromas, 100% incidence, near 100%. Almost every single patient with MEN2B will have this mucosal neuromas. Very, very important point. Which means without this mucosal neuromas, you cannot diagnose MEN2B. Clear? Number 2, these patients may have Marfanoid body habitus. Again, a very commonly tested area in exam. Marfanoid body habitus. So, 3 M's you have to remember for MEN2B. MTC, Marfanoid body habitus, mucosal neuromas. Whereas you remember 3 P's for MEN1, that is pituitary adenoma, parathyroid adenoma, and a pancreatic neuroendocrine neoplasm. All right, there are third thing that can be seen in patients with MEN2B, that is intestinal ganglioneuromas. This happens in the intestine. These are intestinal ganglioneuromas. And again, similarly, you can see other tumors with MEN4. MEN4, we discussed parathyroid adenomas, we saw pituitary adenomas, but there are some extra endocrine tumors that can be seen in MEN1 and MEN4 syndromes, like your reproductive organ tumors. What are the reproductive organ tumors? You can get testicular tumors, or even you can result in neuroendocrine cervical carcinomas. Neuroendocrine cervical carcinomas. They can also develop adrenal and renal tumors, rarely. Adrenal renal tumors also. But these reproductive organ tumors, the testicular tumors, are very, very, very commonly tested area in the exam as well again. MEN4. So in MEN4, only 3 things you have to remember. CDKN1B, and ultimately you have to remember that pituitary adenomas and parathyroid adenomas can be seen in MEN4, and this testicular tumors, that reproductive organ tumors. Extra endocrine features, the most important, please do remember this foregut carcinoids for MEN1, and this cutaneous lichen amyloidosis for MEN2A, and this mucosal neuromas and Marfanoid body habitus for MEN2B, and remember this testicular tumors for MEN4 syndrome. Do you understand? Yes. So these are the different extra endocrine features or other features that you have to remember for MEN4, different MEN syndromes. Okay, and what is the inheritance? We didn't discuss about the inheritance patterns. Remember, almost all the MEN syndromes are autosomal dominant in inheritance. They're autosomal dominantly inherited. All right. So you need to know the screening for MEN2. This is really, really important. So the MEN2 screening. This is very famous for exams again. How will you screen a MEN2 syndrome? Depending on the codon again. So you have to see underlying genetic mutation. So let us take 3 mutations. One, we have discussed this codon 918 mutation. Then you have this codon 634 and 883 mutations and all other mutations. Basically, what is the risk of developing MTC? The codon 918 has the highest risk, which is associated with MEN2B. I think we discussed MEN2B, codon 918, highest risk. Here you have high risk, here you have moderate risk. I mean, I'm not telling low risk. Any MEN2 red proto-oncogene mutation will have high risk of MTC. We are talking about the red proto-oncogene mutations in MEN2, screening on MEN2. So remember, when will you do a prophylactic thyroidectomy? You have to do a prophylactic total thyroidectomy. Since these patients' children are at highest risk, so whenever a child is born to a parent who is already having a MEN1 or a MEN2 syndrome, you are going to test the child for a red proto-oncogene mutation. If the child tests positive for red proto-oncogene mutation, then you see what is the codon mutation underneath. The child tests negative, no need to do anything because the child has escaped. Only 50% chance, isn't it? The child tests positive for red proto-oncogene mutation, see what is the underlying codon mutation. If the codon mutation is 918, do prophylactic total thyroidectomy in the child within a year. Other mutations you can do within 5 years of age, no problem. But this is the highest risk, isn't it? That's why you have to do prophylactic total thyroidectomy within 1 year. You know very well, the most common cause of death in these patients is MTC only. So that's why do total thyroidectomy prophylactically even before MTC can kill you. Good strategy, and you have to plan it accordingly. Then, what about pheochromocytoma risk? Pheochromocytoma risk is there in all these mutations, but when you will do the screening, usually we do around 11 years in case of 918, and we'll do it again 11 years in case of 634 and 883. In all the other mutations, we do it 16 years, start from 16 years. Then screening for MTC screening. Here we do soon after birth. That's why we do prophylactic total thyroidectomy within a year. Soon after birth, you have to start the MTC screening. And in 634 and 883, we start the screening by around 3 years of age. Whereas in all other mutations, we start the screening by 5 years of age. And for hyperparathyroidism, right, HPT, hyperparathyroidism screening because of the, parathyroid adenomas, hyperparathyroidism. So remember, for 918, it's not needed because this is not associated with hyperparathyroidism. You can go back and check. I told you MEN2B is associated with usually 918, and you actually don't get a parathyroid adenoma, isn't it? You don't get a parathyroid adenoma. So that's why I'm clearly telling you don't need screening for hyperparathyroidism if you're harboring a 918, because the characteristic feature of this 918 codon mutations of red proto-oncogene is not to produce this parathyroid adenomas. And we didn't discuss about that one point, like this parathyroid adenomas that you generally get in MEN syndromes tend to be multiglandular. Whereas in common public, you get a parathyroid adenoma that is usually uniglandular. Only single gland will usually be affected. Most commonly affected gland in sporadic tumors or in general population is the right inferior gland. That's what is commonly affected by adenoma in general population. That's the common entity also. But in the familial parathyroid adenoma, when the parathyroid adenoma is associated with MEN2 syndrome or MEN1 syndrome, it will be multiglandular. Many different glands will be affected. Very important point again. And very importantly, this 918 mutations and this MEN2B is not associated with parathyroid adenoma. So you don't need screening of hyperparathyroidism for this 918 mutations. But whereas other mutations, you need them. So when you screen, usually we screen at 11 years in case of 634 and 883 and at 16 years in case of other mutations apart from 634 and 883. Remember, you don't need screening screening for 918 mutations. So these are the two important points I want to tell. So even though there are a lot of things that are given in this particular table, two things are very important. Codon 918, you have to do a prophylactic total thyroidectomy within 1 year, and you have to screen for MTC soon after birth, and you do not need a screening for hyperparathyroidism. Other things I don't want. So remember, and other areas you can do prophylactic total thyroidectomy within 5 years of age. Not so urgent. No need to do within 1 year. Clear? So these are some of the important things that you have to note about the MEN syndrome. So I think we have covered MEN syndromes in a decent way. So we are going to move on to another group of disorders called MEONs. These are nothing but multiple endocrine other organ neoplasms. But before moving into the MEONs, let us see some of the images that are important for this MEN syndromes. You can see this, like pinkish to reddish, like plaque-like lesions. These are nothing but cutaneous lichen amyloidosis. But remember, if they give you a picture like this and they ask you what is the type of MEN syndrome, you are going to note it's MEN 2A syndrome. That's all. This is a cutaneous lichen amyloidosis. Very common in the interscapular region, and that's why I'm showing this image. Common location for this cutaneous lichen amyloidosis, interscapular area. And these are nothing but the mucosal neuromas. If they give you an image like this and if they ask you what is the MEN syndrome that is going to be associated, your answer must be MEN 2B syndrome. That's it. These are the mucosal neuromas that you are encountering. Clear? So with this we can move on to the MEON. MEONs, this is multiple endocrine other organ neoplasias. A lot of MEONs are there, multiple endocrine other organ neoplasias are there. Number one is the HPT-JT. That is this hyperparathyroidism and jaw tumor syndrome. HPT means hyperparathyroidism, and you have a jaw tumor. So, and what is a gene that is related? That is called the CDC73 gene. That is the one that is mutated in this HPT-JT syndrome, which is actually present in the chromosome number 1. And what is the product of this gene that is mutated? The protein that is produced by this gene that is mutated is parafibromin. That is the protein. All these are exam questions, and it's seen in chromosome number 1. Clear? What are the clinical effects? Clinical effects, obviously the name tells they are going to produce parathyroid adenomas, plus please note that these parathyroid adenomas tend to be uniglandular, single gland adenomas, whereas in MEN syndrome I told you it's multiglandular, but here it is uniglandular. And they can develop these jaw tumors. What is the usual jaw tumor? They are going to develop this ossifying fibromas of the mandible and the maxilla. Ossifying fibromas of the mandible and the maxilla. This is what they're going to produce. All right. HPT-JT, right? Second one, they can also produce, they can also get this kind of problems in a patient with Carne complex, otherwise referred to as CNC, Carne complex. What is the gene that is responsible for developing this Carne complex? You have two types of Carne complex. One is called CNC type 1, Carne complex type 1, where the gene that is mutated is protein kinase A gene. Protein kinase A gene, which is present in chromosome number 17. The same like NF1 gene. NF1 gene is also on chromosome number 17. This protein kinase A gene is also on chromosome number 17. Remember, this is also referred to as PPKR1 alpha. Clear? The protein kinase A gene only, but other name for that is PPKAR1 alpha or protein kinase A receptor 1 alpha. Clear? So that is the mutation here. Chromosome number 17. What are the effects? Very importantly, they produce atrial myxomas. Very, very important. Atrial myxomas. And second, you can get some endocrine features. At the same time, you will get other tumors also. Let us see all these things. And you have CNC2 also, which I didn't mention. This Carne complex type 2, we don't know what is the gene. It's an unknown gene. We don't know. We have not sequenced yet. So what are the things that are associated with atrial myxomas? Two syndromes are actually associated with atrial myxomas. One is called a name syndrome and second one is called a Lamb syndrome. What do you mean by name? Name is an acronym for this blue nevi. A stands for atrial myxomas and M stands for myxoid neurofibromas. Myxoid neurofibromas, and E stands for ephyllites. Ephyllites are otherwise called as freckles. We know, I can write E stands for ephyllites. Ephyllites are nothing but freckles. You know, everyone knows what is freckles. And what the Lamb syndrome? Lamb syndrome, L stands for lentigens. AM stands for atrial myxomas. And B stands for this blue nevi. So these syndromes are very commonly asked in exams. So name and Lamb syndromes, and it's associated with cardiac complex, atrial myxomas. And what are the endocrine features? The one of the important and special endocrine feature of this cardiac complex is something referred to as PPNAD or PPNAD. This is called primary pigmented nodular adrenal disease. So this is called primary pigmented nodular adrenal disease. So what they are going to produce? They are going to produce Cushing syndrome, all right. But there are a lot of interesting features about this Cushing syndrome. What are the interesting features? Number one, they tend to be intermittent and cyclical. They're not continuous Cushing's. Usually Cushing syndrome is continuously, they will produce excess cortisol. But this PPNAD will not produce continuous secretion of cortisol. They're going to be intermittent and cyclical production of cortisol. And the patients who are affected with Cushing's here tends to be thin. It's called thin Cushing's. Very, very rare. Isn't it very interesting? You don't usually in Cushing's the patient tends to be obese, but here the patient tends to be thin. And number three, whenever you give dexamethasone, usually you give dexamethasone, there should be suppression of cortisol, isn't it? But giving dexamethasone here will result in paradoxical elevation of cortisol. Clear? So there will be a paradoxical elevation of cortisol after giving dexamethasone. Very, very interesting. You know, like completely different from what you see in Cushing's. In Cushing's, the way you diagnose Cushing's itself is dexamethasone suppression test. But here the patient will have cyclical production of cortisol, thin patients, and at the same time they can have this paradoxical elevation of this cortisol in response to dexamethasone, which is, you know, like out of the world question, you know, like something mind-boggling. You don't get at all. So what are the other tumors you can get? Other tumors you are going to get are psamomatic melanotic schwannomas. That's called psamomatic melanotic schwannomas, or simply you can remember them as schwannomas. And you can get testicular tumors also. Even they asked what is the most common testicular tumor you will get. That is a Sertoli cell tumor. That's also once upon a time question. I think NEET 2015. Then you can get a lot of other findings also, but that is not needed. So we'll close down with testicular tumors here. But you also have to remember this cardiac complex is never equivalent to something called a cardiac triad. So remember simultaneously, cardiac triad is a completely different entity and it is not going to be anywhere near to the cardiac complex. What is cardiac triad? It has three tumors. One is called a GIST. That's called a gastrointestinal stromal tumor. We know that. We'll discuss later on in GIT section. And you're going to have this extra-adrenal paragangliomas. Extra-adrenal paragangliomas. And you can get a pulmonary chondromas. Pulmonary chondromas. Clear? So this is a completely different entity. Cardiac triad. It's a triad of three tumors. And it is not a MEON. Not a MEON. Cardiac complex is a MEON, whereas cardiac triad is not a MEON. Be very clear about that. So we have discussed in details about the cardiac complex. The most important question on cardiac complex will be from the PPNAD. Please never forget this PPNAD. Primary pigmented nodular adrenal disease. Never forget it. Clear? Now number three, the third MEON or third multiple endocrine other organ neoplasia will be the McCune-Albright syndrome. McCune-Albright syndrome. So what is this? What is McCune-Albright syndrome? So, you know the mutation will be in the gene as gene. That is nothing but GS alpha mutation, and it is a random mutation. Random mutation. Clear? Random mutation of the GS alpha. That's why I told you there are 4 things that are associated with this GS alpha mutations. 4 important things that you have to know. If they ask you in exam, what are the diseases that are associated with GS alpha mutation? This is G protein, like in GS subtype, in GS alpha, like protein mutation, where will you get? Number 1 already we discussed. Let us start from that. That is 40% of the growth hormone secreting pituitary adenomas, that is somatic adenomas, tend to have this GS alpha mutation. Second, just now we saw McCune-Albright syndrome. Next 2 entities you have to know, that is pseudo hypoparathyroidism type 1A. Pseudo hypoparathyroidism type 1A. Number 4, you can get with congenital nephrogenic diabetes insipidus, that is X-linked. It is due to mutations of the V1 receptor gene mutations. That is due to mutations of the V1 receptor. So 4 diseases, it has to be in fingertips. Very, very common exam questions. 40% of the somatic adenomas, and McCune-Albright syndrome, that is pseudo hypoparathyroidism type 1A, and finally you have this congenital nephrogenic diabetes insipidus, that is that V1 receptor mutations which are X-linked. So all these 4 are very, very important. These are due to GS alpha mutation, that is the gene as gene mutations, can result in any of this disorder. Okay. What is McCune-Albright syndrome? You know, it's a triad. What's a triad? We already discussed. 1 is going to be the hyperpituitarism. Hyperpituitarism. Or I can write hyperfunctioning endocrinopathy. Or you can write hyperfunctioning endocrinopathy. Very commonly, they will end up with excessive gonadotropins or GnRH production, resulting in precocious puberty. You can result in precocious puberty. Next, or they can even result in a growth hormone excess state also. That is also possible. Next, we are going to have caffiole macules, and you can also develop this polyostotic fibrous dysplasia, especially of the long bones, which might result in Shepherd-Crook deformity of the femur. So this is a characteristic triad of McCune-Albright syndrome. Like it was one of my orthopedic medal exam cases. In my orthopedic medal exam, they kept this McCune-Albright syndrome because they have this fibrous dysplasia. And it was a young girl. I still couldn't forget that girl. She had all the features, caffiole macules, and this was one of the cases that fetched me the orthopedics medal. Okay. Number 4, you can have something called neurofibromatosis type 1, that is otherwise referred to as von Recklinghausen disease. That also will come under this MEON only. Why, I will tell you. Basically, it is due to mutations of the NF1 gene, which is present on chromosome number 17, and the product of this gene is going to be something called neurofibromin. There are a lot of endocrine and other extraendocrine features, but the most important is the extraendocrine features. These patients will have neurofibromas, and they have optic nerve gliomas. Clear? As a main tumor, they can have caffiole macules, these Lish nodules in the eyes, then axillary freckling. A lot of features are there, but important endocrine feature here will be the pheochromocytoma. Very, very important. If at all they give a patient with pheochromocytoma and a caffiole macule, always answer it's a neurofibromatosis type 1, von Recklinghausen disease. That's what they are trying to suggest in exam. So this is a very, very important thing. This is an endocrine feature. These are the other tumors. That's a multiple endocrine, other organ neoplasias. Then 5th one, you have von Hippel-Lindau syndrome. You know it is due to mutation of the VHL gene, which is present on chromosome number 3, and the product of this VHL gene is something called elongin. Elongin is the product. So VHL is going to be associated with multiple different tumors. In that, one of the important tumor is the cerebellar hemangioblastoma. They can have cerebellar hemangioblastoma. They can even have polycythemia also. But this cerebellar hemangioblastoma is going to be the most important tumor in von Hippel-Lindau syndrome. At the same time, they have one important endocrine tumor also, that is again a pheochromocytoma. Pheochromocytoma is a very, very important endocrine tumor here. Fine. Similarly, you have Cowden syndrome. The most important type of Cowden syndrome is type 1. That's the most important for our discussion. And they are going to be due to PTEN mutation. Multiple mutations are there, but PTEN mutations tend to be the most common. Most common mutations with Cowden syndrome is PTEN mutations. Let us discuss about GET chapter because it's going to cause intestinal polyps. Because of that, you're going to get this Cowden syndrome, and you have a lot of syndromes that are associated with intestinal polyps. We'll discuss that later on slowly. But this is another MEON that you have to know. This is Cowden syndrome. Remember, almost every single MEON which I have described till now, every single MEON which I have described till now are autosomal dominant in inheritance. The only exception is McCune-Albright syndrome. McCune-Albright syndrome, which is not an inherited disorder. In fact, this is a sporadic disorder. It's a sporadic disease. It's not at all an inherited disease. McCune-Albright syndrome. It's like neurocutaneous syndromes only. In the neurocutaneous syndromes, you know that all the neurocutaneous syndromes are actually autosomal dominant except Sturge-Weber syndrome, which is not at all inherited, it's sporadic. Similarly, all the MEONs which I have described are autosomal dominant inheritance except for McCune-Albright syndrome, which is actually a sporadic disorder. It's not at all an inherited disorder. I think you can have a good grasp of what do you mean by a MEN and what do you mean by a MEON, and what are the features of MEN and what are the features of MEON. And the most important is the codon mutations in red protoncogene, especially of MEN2. Certain points they will ask you in exam. And I think we have covered almost everything in a very decent way, in a very easy way as well, because the table, whatever I've given you, it's a comparison one and it's really easy for you to understand in the exams. So with this, we can close down the MEN section and the MEON section. In the next section, we'll be moving on to the autoimmune polyendocrine syndromes.